welcome everyone to the second myasthenia gravis webinar series we are organizing through Neurology Academy with the support of Argenex. So this webinar, if you missed your first webinar, then our webinars are organized as two-part session. First part is where we discussed about a clinical aspect, and then in the second aspect part of the webinar is a sponsored webinar by Argenex, where we have today we have three speakers, and that'll happen after a short break. So may I invite John, please take it over.
Very good. Remember, everybody, put questions in the Q&A, and we'll try and deal with them. I've about 20 minutes, I think, which isn't very long. The title was about biomarkers and clinical rather than chemical markers, but I haven't stuck too much to that. I have a bit of that at the end. I'm not sure how much time there'll be for that, but we'll try and get on with it. So it's really about B-cell therapies and myasthenia gravis, my perspective on where they might fit in, my perspective on what the literature tells us to date, we'll crack on. So honoraria from used to be neuromuscular clinicians were not courted by pharma too much, but things have changed in recent years. So I have a few honoraria for speaking for a few things, but that's only disclosures. Myasthenia gravis. My first point is really that it sounds like it's a disease, but of course it's not. It's a syndrome, isn't it, with a common pathophysiology, which is impaired neuromuscular transmission, a particular type of postsynaptic neuromuscular transmission, which is antibody-mediated. And it encompasses probably a range of at least these diseases, I think. I'm going to call these diseases because they're homogeneous to some degree populations with specific kind of, HLA associations and antibodies and age-specific onsets and various things. So MuSK antibody, that's a different thing, isn't it? It's IgG4 disorder. It's quite discrete from the acetylcholine receptors. And then we have overlapping populations of early onset myasthenia with antibodies. Thymoma, peak onset sometime around about 50 or so with antibodies, a different thing. We've late onset myasthenia gravis, much more common than the others in the UK at the minute, though not the way the historical epidemiology looked. And then others, which I've called less well-defined groups, the degree to which they're part of the other subgroups, I'm not so sure, seronegatives, LRP4 clusters, whatever. So remember that it's not necessarily a one-size-fits-all. I think MuSK and SEHR are quite different. Antibody disorders are quite different with respect to our expectation of the response to rituximab. Biomarker number one, antibodies. They tell us what disease you have. They give us something. They tell us that you may have a thymoma going on, and also about 10% of people, and they give some idea of responsiveness to rituximab therapy. So my point number one is, I hope, an obvious point, although sometimes not very obviously made, and that is that B cells are not plasma cells. Plasma cells are not B cells, rather. They derive from B cells, and often people talk about myasthenia like it's a B cell disease, but of course it's an antibody-mediated disorder, and B cells are intrinsic to the pathology because they produce the antibodies that then mature into plasma cells, which produce the antibodies. They don't produce the antibodies themselves, and they're critical to T-cell interactions. They're critical to responding to the antigen, but so they're fundamental to the pathology, but they're not the producers of antibodies as a general rule. It's a slight oversimplification, perhaps, because although plasma cells, these long-lived antibody-producing factories, which we think are the key thing behind acetylcholine receptor antibody myasthenia gravis. The MuSK is slightly different because we have some plasmablast, and much more short-lived plasma cell pool, which is IgG4 producing, which seem to be critical to the pathogenesis. So that's a really important difference, because plasmablasts have some CD20 on them and are seen to be replenished quite frequently from the B cell pool, and plasma cells don't have. CD20 being, of course, the antigen that rituximab works at to clear, plasma cells not. So just reminding you again that CD20 is not in plasmablasts and plasma cells. In many ways, that's a good thing. It means your immunoglobulin pools, your immunoglobulin memory, if you like, is relatively unaffected by CD20 clearance, at least in the short term. In the long term, we see immunoglobulin depletion, whereas CD19 is a slightly broader marker, which we haven't really, I'm not going to talk about, and we haven't really got into to use, and some of these other antigens are, of course, are different distribution. But CD20, not plasma cells, not pro-B cells, and that may be useful, but limiting and also useful at the same time. So it's not that, as I said, B cells are unimportant, because Immunoglobulins are important, and immunoglobulins are the result of hypermutation of B-cell immunoglobulin genes, which of course give rise to the plasma cells, and of course IgG subclass, and how these B-cell switch is important in selecting the kind of the potential pathogenic mechanisms of antibodies. I'm not going to get too much into this, but I mean, I think a really important distinction is between the IgG1 disorder, like predominantly IgG1 complement-mediated and other effects, but probably predominantly a complement-mediated disorder for many people, and that's an oversimplification of the acetylcholine receptor antibody disorder. So the effector functions are important. IgG1 is a complement fixation, Fc gamma receptors. Immunological memory, a very different long-lived plasma cells with antibodies, and rituximab. Where does it fit in? I'm going to argue that it's largely, currently at the minute, something which is an induction, useful for induction of remission of myasthenia gravis and reducing your long-term immunosuppression need. But we'll get into that in a bit. MuSK, a different disorder, IgG4 mediated. IgG4, a very different type of antibody, a relatively inert immunoglobulin with high affinity, typically monovalent. We see. Close the door, please. So my son's just walked in. I'm just asking him to close the door. So we think this is not, it's a functional inhibition of MuSK activation. We think that the antibody is produced by cells which are constantly replenished from the B cell pool, and for which plasmablasts, these sort of cells which still have some CD20 on them, but are maturing into plasma cells, that they're important for IgG4 production. And we see early and dramatic impact of rituximab when I talk about that in a bit, and induction of remission, and again long-term reduction in immunosuppression requirements are probably the case with rituximab use in MuSK. So goal, I've got two ways of stating the goal. A kind of physiological goal. Here's my physiological goal, which may sound like a terrible pedant's goal, but the goal is, I think, in myasthenia treatments to increase the safety margin for neuromuscular transmission such that no block occurs in physiological conditions. That's a terrible definition, isn't it? So the notion is we're going to reduce the amount of pathogenic IgG or the effects of pathogenic IgG to a level that allows for reliable neuromuscular transmission. So I have a few thoughts there that you can read about what lots of assumptions about the relationship between antibodies and blockade that are necessary as we go from cells to antibodies and into rescue of the myasthenia picture, the phenotype. So probably a more sensible clinical goal is to achieve remission or minimal manifestations with minimal risk, a short and long-term side effects at a maximum rate, at minimum cost, and to maintain remission at minimal cost and risk, and perhaps to increase the likelihood of drug-free remission. And that's kind of, these are considerations to be given when we're thinking about our therapies. Where do they fit in? To what extent do they do these things? So I'm going to start not with rituximab, because I think it's important to see where rituximab fits in, to briefly talk about thymectomy and early onset myasthenia gravis. So a one-off intervention with medium-term impact on disease severity and steroid requirements, and we think with long-term reduction in steroid requirements and increased likelihood of remission. So that would fit our goal. And the question is, does rituximab fit some similar goal? This is a brief reminder of the sorts of outcomes that we saw in the randomized thymectomy trial in myasthenia gravis. We saw reduced steroid requirements and better scores, reduced weakness as a consequence of thymectomy, occurring reasonably quickly. The divergence is quite quick. Within 3 to 6 months, we're seeing some divergence, and certainly by 9 to 12 months, we're seeing a good effect in prednisolone dose. Prednisolone dose, by definition, follows the improvement in scores, because the downward titrations were titrated downwards as a result of improving myasthenia scores. So we see divergence quite quickly, actually, which I think was a surprise to the people in the trials, within 3 to 6 months or so. Interesting when you look at this is a box and whiskers chart for the people who were randomized to the thymectomy trial, and you see the median age was 33. And this is we don't have very few. This goes a fair way, but there are, I think, about 7 people who were over 50 in the 9 people over 50 who were randomized to thymectomy. And this is the current UK population, at least as far as Northern Ireland is concerned. And you can see that actually this is a small minority of the current population of acetylcholine antibody positive myasthenia gravis people. Each dot is a person in our and this is age-specific incidence effectively as a dot plot. So here we are another way. This is, we pulled out thymoma here, and we've pretended that we can identify the late onset myasthenic people by skeletal muscle antibodies, so you get a sense of the overlapping notions of early onset and late onset. This is about 80% sensitive for late onset, so this is probably a bigger population. And you see where the trial median fits in, and how there were very few people over 50, which is a bulk of our population. So what about the bulk of the population in non-thymomatous late onset myasthenia gravis? It's just a, and I think that's where the rituximab, I'm starting, it's 12 minutes in, where rituximab comes in. Rhinomax, I hope you're aware of a randomized trial of rituximab versus placebo as an add-on to standard therapy in myasthenia gravis. I'm drawing attention to your average age, which was 67 with a standard deviation of 13. So this is right in the heart of our late onset population, and this is a 500 milligrams of as a stat dose of rituximab given within the first year. Most people are at about a 5 months duration as a typical duration of symptoms. They were not to have had a thymoma or thymectomy beforehand. You know, this, I say 67, I'm drawing your attention to the age here, and this is generalized myasthenia gravis, not ocular myasthenia gravis, and a reasonable kind of clinic population, prednisone at baseline. You see the various doses, and the effect was quite dramatic and impactful. This is their first endpoint at 16 weeks, already seeing marked differences in people who got the minimal manifestations by 16 weeks in rituximab versus placebo. Pretty convincing and reasonably sustained in the subsequent follow-up points, but perhaps not quite as dramatic as in the first 16 weeks, but sustained throughout the follow-up period, which is 12 months, as far as I recall. It's interesting. This is serious adverse events, reasonably similar as between the placebo. In fact, if anything, if you included the myasthenic crisis as a serious event, the event frequency was lower in the rituximab than in the placebo population. And this is an important slide, I think, because the divergence in the need for rescue therapy was quite significant, and again quite early within that initial 3 months or so. We're seeing a rescue, or a significant reduction in the number of rescue therapies required in rituximab versus placebo. I know the confidence intervals are quite broad here, but this wasn't a primary endpoint of the trial. So we've convincing efficacy. That's the point. It's early. And the population served, I'm plotting it again on top of my Northern Irish population, because I think we could argue, I think we should argue, that we've randomized trials that give us clarity over early interventions and generalized early onset and late onset myasthenia gravis for what we should do in people with acetylcholine receptor antibodies and generalized myasthenia. So the thymectomy trial tells us that we can certainly modify the outcome in these early onset population, and Rhinomax looks rather similar, except the median is here with a confidence interval which stretches right up to another confidence interval, a standard deviation which stretches up to 80. So this is the dominant population in Rhinomax, and I think a pretty convincing trial, a single dose of rituximab. MuSK is worth talking about. Unfortunately, we don't have a randomized controlled trial in MuSK. I'm listing here all the things which neurologists probably manage with reasonable degrees of confidence, I hope, and I think we're lumping all of these IgG4 related disorders together. When you see an LGI1 encephalitis, Caspar-2 acquired neuromyotonia, when you're seeing those neurofascin and contactin associated nodopathies or paranodopathies. I know we don't see pemphigus and immune ITP and PLA2 membranous glomerulonephritis, but there are about 14 IgG4 disorders, and a fair number of them are the sorts of things that we see in neurology. And I think we should, in all of these conditions, we should be thinking about early rituximab. So this, there are some RCTs in nephrotic syndrome. This is an RCT in pemphigus, which I'm showing really just to I suppose to connect together these IgG4 disorders. I'm not sure how legitimate that is, but you see this really dramatic early impact on the severity of pemphigus, which is an IgG4 antidesmoid-lion disorder. MuSK has had a type of blinded prospective kind of trial where people were given notes and asked whether they would randomize to MuSK or not from multiple centers in the United States, or randomized to rituximab or not in multiple centers in the United States, and they did a kind of pretend prospective randomized trial with that with people who with it was the equivalent of some sort of propensity mapping to try and match control groups and those who were treated as if a randomized trial. And you see we've got 24 versus 31 treated, non-treated, and the divergence is quite significant. And to the extent that actually most people would find it hard to justify randomizing people to placebo, I think with severe generalized myasthenia gravis on the basis of MuSK antibodies, so the effects are rapid and dramatic. This is a minimum manifestations in 5 milligrams of prednisone or less type measure. So rituximab dramatically and quickly showing benefit over control or a placebo, not placebo in this case, but people without rituximab treatment. So that seems pretty clear. Early onset myasthenia gravis, we have thymectomy. To use late onset myasthenia gravis, this is generalized acetylcholine antibody, rituximab, and MuSK antibody, generalized myasthenia gravis. They're almost entirely generalized and severe disorder, and that's 6 minutes to go. So what about treatment refractory myasthenia? Are the useful biomarkers, alternative B-cell depletion? We've got about 6 minutes to get through this, so I'm going to go rather quickly. Beta-MG, this was a trial, a kind of futility trial, and unfortunately the placebo arm did better than expected, which reduced the power to show futility. But even so, the impact was really impossible to see. And this is people with 6 or 7 years of treatment, a population age 53, which would have spanned the early onset and late onset disorders, but really very hard to see any sign of a treatment effect. And that puts in question our current use or the historical use of rituximab in the UK, which has been for late onset, or which has been for refractory myasthenia gravis. It's not without some hint of effects. This is again the total number of relapses requiring rescue therapy, which was much greater in placebo than rituximab. So again, a sniff of that effect on sparing rescue therapy, and it's possible because this is an intention to treat that some of these people had rescue therapy and that improved their scores rather than being their true untreated score for rescue therapy. That may have messed up some of the statistics here, but so it's hard to justify at the minute. It's hard to say one way or another with respect to late onset or to treatment refractory myasthenia gravis, but this sparing effect on rescue therapy, I think, was evident. So biomarkers, that was what the title kind of came. I wasn't really the title I was working to. Are there biomarkers that are useful? B-cell depletion, T-cell and general lymphopenia, B-cell recovery. Here's a plot of our anti-MuSK myasthenic patient that we treated with small doses, 100 milligrams of doses of rituximab in the old days when rituximab was very expensive, and the ITP literature had a good literature on 100 milligrams being quite efficacious. We kind of systematically we're looking at lymphocyte subsets to see if we were getting therapeutic efficacy with respect to B-cell depletion on rituximab. So we actually do see B-cell depletion. You see these low levels sometimes in NHS assays, like 0.01s or something, which is 0.1 here. We couldn't really tell whether it was artifact or not. So I've plotted them here, but really the notion is that almost entirely, even with 100 milligrams, we see complete depletion of B cells in my experience. Whereas 500 milligrams is what the guys were using in the Rhinomax trial. But interestingly, if you check T cells quite quickly, we see marked rapid drops in CD4 and CD8 counts, which rapidly recover actually. And that was a pretty predictable thing. So we do see quite prominent lymphopenia, including T cell lymphopenia. I'm not sure what it means. I suppose it means increased risk of lymphopenic associated infections, but otherwise I think the effects are rather transient. So lymphocyte counts, they certainly are useful to measure to see if your drug's been efficacious. And although we think that people are systematically depleted with rituximab, their B cells all deplete, all the circulating B cells deplete. There's certainly clear in the rheumatology literature that that's not always the case. That certainly in SLE, there's a reasonable proportion, a modest proportion of people who don't deplete, and these people are not suppressible. Now SLE is funny; it's immune complex mediated. It's some SLEs about clearing immune complexes, about disorder of immune complex clearance and other sorts of innate inflammatory mechanism clearance sort of issues. So there may be some specific issue with SLE that makes rituximab's complement mediated element doesn't work so well, but it reminds us that in real biology we can't absolutely rely upon the depleting effects of an antibody, and therefore checking, particularly using low dose, seems reasonable to me, and checking the time to recovery is useful, particularly because we often add in something like a methylphenolator isothiazide, putting rituximab on top, and therefore the reliability of the B cell recovery is impossible to tell. In my experience, once more, there's a very prolonged depletion if you're using an anti-lymphocyte drug like methotrexate or mycophenolate or azathioprine along with rituximab. Okay, it'd be nice to know if there were how systematically depleted the CD20 cells were. These are spleens from people with ITP, and showing some persistence of CD20 positive cells following rituximab, i.e. what's the degree to which there's tissue depletion of rituximab or tissue depletion of CD20 positive cells in rituximab treated patients. And it's actually not very clear. It certainly does decrease tissue levels in terms of the spleen. And this was the time, because remember, these people get rituximab and then they get a splenectomy some months later. And there was certainly a relationship between the time between rituximab and splenectomy, which gives the impression that perhaps this is B cell recovery rather than fetal B cell depletion. But it's really quite hard to tell the degree to which we completely deplete the CD20 cells. Well, the antibodies useful. I don't think I'll get into that too much. Certainly, they're useful for defining your syndromes, your IgG4s versus your IgG1 mediated disorders, and therefore anticipating the degree to which we can expect rituximab to have effect and the rate at which can have effect. But it's a whole different talk about the reason why or why not antibodies are useful markers of disease severity in myasthenia. They certainly have some utility. Rituximab risks. I've put some in there. You can see I'm going to keep moving on. Immune globulin deficiency with repeated dosing, I think, is important, and certainly prolonged B cell lymphopenia if you're using conventional steroid sparing agents, I think, is also important to know about. Infusion reactions with lymphocyte depletion is really common. Alternative agents I haven't discussed. Rituximab we think is largely complement mediated. These other drugs are ocrelizumab, obinutuzumab are better with antibody dependent cell cytotoxicity, rather than cell cytotoxicity rather than complement mediated. And there are benefits and upsides and downsides of that. CAR T cells I haven't discussed, and bispecific and trispecific monoclonal antibody hybrids linking CD20 with other type of like CD3s and things to try and improve cell-mediated killing of B cells. Why am I to be ineffective? I think I need to crack on. So very occasionally we'll see a myasthenic myopathy that's irreversible. End plate myopathies, I think it's something might be overplayed in the literature, and I think by and large there's significant reversibility with end plate disease, but occasionally we see myasthenic myopathies which have fatty change that I think have limited chance for recovery, particularly in the MuSK stuff. So inadequate immunosuppression, antibodies, plasma cells, B cell escape plasmablasts. I haven't got into those because there's not much time. So the summary: B cells are fundamental development of pathogenic antibodies. Plasma cells are not directly targeted by anti-CD20s, but with class 1 evidence of efficacy in actually says early acetylcholine receptor, actually it's late acetylcholine receptor antibody myasthenia gravis, but early use. We've a body of class 4 evidence for efficacy in MuSK myasthenia gravis, and we've class 1 evidence for futility at 52 weeks in established refractory myasthenia gravis, and that I think I should leave it there. Okay.
Well, thank you so much, John, for that very informative talk. Now that you have whetted our interest about rituximab, and let me invite Natasha, who's a neuropharmacist, to talk to us about how we need to prepare our patients in order to offer them rituximab in our clinics. And after Natasha's presentation, which is about 10 or so minutes, we will then move on to the question and answer session. Over to you, Natasha.
Wonderful. So I'm going to briefly talk about preparing a patient for rituximab. Just put my disclosures there. And for a quick overview, I'm going to discuss the pre-screening testing, a little bit about vaccination and considering comorbidity, some of the counselling points, and then finish with a little bit about the funding. So on the screen here, we can see the different tests that we usually carry out for a patient being started on rituximab. We can split them into essential and desirable. So for the essential tests, these are ones that normally come back quickly. I've highlighted the HBV serology there because I'm going to expand on that a little bit more, but that's one of the most important tests. We look at things like immunoglobulins, because if people have low IgG, particularly before we start the rituximab, they're more likely to have infectious complications along the way. Where possible, so where a patient is having elective use, we carry out some further tests, so VZV serology, making sure that the patient has either had chickenpox or is immune, quantiferon TB, which again I'm going to expand on a little bit, and ECG if there is a history of cardiac disease. This isn't always necessary, so rituximab isn't a cardiotoxic drug in itself, but worsening of conditions like angina and heart failure have been observed, although this can also be disease specific because the incidence is typically higher when treating ANCA vasculitis. So here on the screen, I've just kind of outlined the different results you see, so comparing current HBV infection, latent and reactivation. So rituximab and other anti-CD20s are one of the immunosuppressants with highest risk of hepatitis reactivation. And this is because there is a depletion of the T memory cells. So if a patient is re-exposed, they're more likely to reactivate. This can be prevented with antiviral drugs, so we typically use entecavir, and this needs to be taken throughout the whole treatment period. And usually for patients only on a course of rituximab, it would continue for about 12 months after the last infusion, although this would be discussed with infectious diseases. One thing to note with the antivirals is that they have a huge number of drug interactions, so just to bear that in mind if they have any other comorbidities. One thing that we also come across as well is passive hepatitis B serology, typically through blood products like IVIGs. And this might be because the particular batch was collected for a patient undergoing seroconversion, and this isn't something they can test for. So unexpectedly, you can get kind of false positive results, or almost like passive vaccination of the hepatitis B. And again, these cases can be discussed with ID. For tuberculosis, it's actually probably more prevalent than we think. So in 2019, it was estimated that about 24% of the world's population had latent TB. It is lower within the UK, although if we're practicing in cities, but I'm guessing a lot of us are, We probably actually come across this quite a bit. And I know in my practice, I usually see a handful a month of patients that I'm screening for immunosuppression. When we have time, we do recommend quantiferon TB goal testing. However, positive results can't differentiate between latent or active TB. So if you do get a positive result, we tend to do chest x-rays and further investigations along with the infectious diseases team. Very commonly, we see indeterminate results, and this is common in people who are immunosuppressed, particularly with steroids. So if a patient is already established on prednisolone, they've got about a 30% chance of getting an indeterminate result on the test. And this is because the test relies on the release of interferon GABA in response to mycobacterium. So it's not having that response as expected. If we do have a case of latent TB, in our practice, at least in Sheffield, we tend to use rifampicin, and this goes on for 4 months. Other first-line agents include isoniazid, but this is known to cause peripheral neuropathy or worsen it, so not ideal for those with neurological conditions. And our usual kind of treatment pathway is we'd give 1 month of the TB treatment, and then the patient can start immunosuppression and then finish the 3 months whilst receiving treatment. For vaccination, it's always good practice to take immunisation history, and this is because live vaccines need to be avoided 4 weeks before treatment and for at least 12 months after the last infusion. Inactivated vaccines, which kind of covers most of those that we use most commonly, they are safe to give, but those who are immunosuppressed can have a suboptimal immune response. So where possible, we give at least 2 weeks before starting the rituximab. And with these patients, generally influenza, pneumococcal and COVID vaccines should be encouraged. They're generally all inactivated, and even if they don't respond fully, it's considered safer to give them than not to. I'm not going to dwell on this too long, but it's just a table kind of summarising the vaccines we'd advise routinely, those we could consider, so hepatitis B vaccination if a patient is at high risk of exposure. The rules have recently changed for shingles vaccination, so now it can be given to those over 50 that are immunosuppressed. We have a live vaccine, which is Zostavax, and the inactivated Shingrix, which we'd recommend. Where we can get into some treatment delays is the varicella vaccine. So unfortunately, we only have live vaccinations. If a patient isn't immune to chickenpox, you would need to have a conversation with them, either to delay treatment, have a course of the Varivax. So that would delay treatment for about 12 weeks to complete the course, or to report to a healthcare professional if they come into contact with anyone whilst immunosuppressed. And the list there of live vaccines, they're just the current live vaccines available in the UK if you get any queries. So for assessing comorbidity, there's quite a few things to consider. So in terms of contraindications, it is recommended we don't give rituximab in those with uncontrolled heart disease. We should take an infection history, especially if these are patients that are already on things such as mycophenolate, methotrexate. And one of the useful or easier ways we do this is by looking at the number of antibiotic courses issued by the GP over the past year or so. We can check for polyautoimmunity. So if a patient has one autoimmune condition, they're more likely to have a second or even a third. Rituximab is licensed and it's used for a wide range of conditions. It's useful for most. However, it can exacerbate inflammatory bowel disease and psoriasis. So they're the two that it wouldn't be ideal in. Whereas there may be an alternative treatment that would be beneficial for both conditions. We need to check if any surgeries are planned because of the delay to wound healing, increased risk of infection, consider underlying comorbid malignancies. So generally we wouldn't immunosuppress someone who's undergoing chemotherapy as they will be already, but we can discuss that with the teams and check medication histories where needed. In terms of patient counselling, we should let them know that the use of rituximab is unlicensed. However, there is good evidence to support its efficacy and it's used commonly. We need to explain benefits of treatment and help manage expectations. inform patients of potential biosimilar switches. So we have a lot of biosimilars for rituximab now, and I know at least where we are, we're asked to switch based on contracting and cost nearly every week. It happens so frequently. So kind of having that discussion with patients on the onset can make this easier. About 30% of patients will have some form of infusion reaction on their first dose of rituximab. This is usually very mild and can be managed with things like paracetamol or antihistamines, but they do need to be made aware of the more serious reactions, the rarer ones like anaphylaxis, and to present immediately if they get things like a swollen tongue or trouble breathing. There is an increased risk of infections, and although the risk of PML is very low with rituximab generally, it has been reported. So patients should be told to report new neurological or cognitive symptoms promptly. And then last but not least, advise the use of effective contraception. So there are lots of different rules surrounding rituximab in pregnancy and pregnancy planning. The manufacturers advise not to get pregnant for 12 months after rituximab. However, in practice, it's not considered to be too risky. We have no evidence of teratogenicity. Rituximab is a large molecule and it can't cross the placenta until the second trimester, when all the organogenesis has typically happened. However, it's not something we can specifically say is safe. Guidelines vary everywhere, but I think a lot of the consensus now is generally about 3 months after the last dose. In terms of other patient considerations, so asking them if they're able to travel to the infusion centre. Again, if they're planning pregnancy or breastfeeding, the manufacturers again advise against breastfeeding, but it's generally considered safe in practice, and we need to consider risk versus benefit. And one thing that we often see in neurology is that we don't have a lot of patient information sources targeted for neurological indications. And some of the things out there can sound quite scary, particularly when you're looking at rituximab leaflets for things like renal transplantation or cancers. It can not necessarily be the most useful thing. And then just to finish off, a little bit about funding. So the funding of rituximab can be quite complex. It's a fairly inexpensive drug now, and some areas may have block contracting in place, but I've just listed here the list of indications in neurology in which we do have NHS England commissioning criteria in place. So there may be reimbursement via Blue Tech. So to summarise, just when we choose rituximab as a treatment option, we need to carry out pre-screening tests, review the patient comorbidity, assess them holistically, counsel and consent them, and apply for funding before giving treatment. And that is everything on my presentation. Thank you.
Thank you very much, Natasha, for that very practical lecture. Okay, very good. We've got a few questions, John and Natasha. The first question is a very interesting one. Why don't we measure CD20 cells? Why don't we measure CD19? Well, in our CD4 subsets that in Hallamshire that I work in, CD20 is not measured. I'm sure there is a scientific answer for that.
I just think it's the NHS. So CD19 is a better B cell marker because it's a broader spectrum. It's a broader spectrum. So the NHS lab will measure CD19s, and actually that's most of the circulating B cells. But so it is perfectly reasonable to measure CD20s to show that your CD20 is working and killing off all the CD20s. But that's a research thing, not an NHS thing. So the NHS will do CD19, CD3, CD8, CD4. So they'll do T cell and all B cells with CD19s. It's a broader marker, as you can see in the thing. That's why.
Yeah, it's a catch-all marker. Yeah. And next question is from Priya from Leeds. Priya, your question is about shingles exposure for a patient treated with rituximab. Are there any precautions the patients can take? Can I forward this to Natasha?
Yeah, so it's general advice at the start. So if they know a person who's got shingles or chickenpox, to try and avoid them if possible. if they do contract it, it'd be to go to the GP straight away for treatment. Fortunately, shingles in adults doesn't tend to be necessarily as serious as chickenpox, but they may still get unwell. So just to avoid people where possible and go to the GP as soon as they can.
Perfect. Thank you. And then the next question is is also a very important question. What do you do about the PCP prophylaxis for patients who are on immunosuppressive therapy? There is an increasing dialogue about uh, providing patients with PCP prophylaxis, particularly if they're on high doses of steroids and immunosuppressive therapy. I think we have discussed multiple times amongst a number of colleagues during our guideline development, etc., whether we should recommend PCP prophylaxis. John, what are your thoughts about particularly those cohorts of patients who are on steroids, on azathioprine or mycophenolate, and has also received rituximab? My rheumatology colleagues would say that they're high risk for PCP.
I have a low threshold for using PCP prophylaxis, particularly if you're adding in. So it's actually one of the reasons why it's nice to measure things. You know, if they're pronounced lymphopenia, which they usually have, then I would certainly have them PCP prophylaxis. I think you're adding in rituximab, you've prolonged B cell depletion, using azathioprine and mycophenolate, methotrexate, something like that on top of it with some high dose steroid. I think they're at risk of PJP. And then, but actually, I got to say, I don't think the rules are clear. I think if you've clearly got significant lymphopenia, like lymphocyte counts of 0.6 or less or something, you should probably definitely be on some sort of PJP prophylaxis. But otherwise, I don't think it's that clear. So my practice is PJP when you're adding something in. That's one of the other agents plus Ritux and steroids, or cyclosporin plus Rituxan on the other, and steroids. I would have PJP prophylaxis, even though there's a relative contraindication, so the cotrimoxazole and cyclosporin, for example. But it's actually not very clear.
Yeah, I agree with you. That is reflective of my practice too. If someone is on 3 agents, then I will have a low threshold. Then next question is about
lymphopenia.
A number of patients have developed prolonged B-cell lymphopenia longer than 2 years after rituximab, and as patients become symptomatic and you're considering retreating these patients, what is your opinion about retreating?
So I would say that I'm going to make an IgG4 versus IgG1 distinction here. And so one of the things I think when the B cells are very low is rituximab, I think, doesn't have an awful lot extra to offer if you've the IgG1 mediated disorder. So it's worth measuring your B cells. You're certainly increasing your risk, as Natasha was talking about, of immunoglobulin deficiency in the long term. If you really have pronounced, certainly they become IgM deficient, and then your risk of IgG deficiency becomes greater, I think, with pronounced and prolonged B cell depletion. But so the IgG1 disorders, I'm not quite sure what to do with those. I wouldn't say never, but I'd be reluctant to think that rituximab is going to add in enormously when you have trivial or no B cells to detect 2 years. I think I can't see why you'd repeat in that stage. I have used it in relapsing, like acquired neuromyotonia, where with Casper-2, where the B cells are just about detectable, but the syndromes come back. It's an IgG4 mediated disorder, and the rituximab works beautifully. The neuromyotonia goes away, and so the IgG4 things, a MuSK, a Casper-2, I think, is a different business because the very cells that escape your CD20 are the plasmablasts. And I think that population can still produce quite a lot of pathogenic antibodies. So that's my distinction. I don't know what you think, Chana.
Is pretty much what I will do. But if someone is low in B cells, I'll be very careful not to treat them, or in fact, I would be careful to treat, because they run the risk of further immunosuppression and B cell depletion. What about this situation, John, where you treat someone with rituximab and their CD19 cell count is now undetectable, but the patient is having a relapse of myasthenic symptoms? They only have had one infusion of 500 milligrams. Would you repeat? Would you think that, well,
I don't think it would do
CD19
any harm to repeat if there are no B cells detectable, but I don't think it'll do much good. You've no B cells, and so I think it depends on what mode of care you're in. You've got your rescue therapies that might bridge you over for a few months. Remember, you have 2 or 3 months to see how efficacy works. So if it's quite early, you might be reaching for your plasma exchange, human immunoglobulin, efgartigimod, complement inhibitor, things to hold you over, and that's perfectly reasonable. Or you might be adding other kind of induction type drugs. But as you know, I'm a calcium urine fan, a calcium urine inhibitor fan. That's not for the faint-hearted in this scenario, because T-cell blockade where you have no B cells is dangerous, I think. So you should be familiar with that. You shouldn't be doing it if it's the first time you've done it. You should be asking your friends, your myasthenia and neuroimmunology friends, to be helping out in that scenario. So rescue therapy and additional induction therapy for sure, but you're in trouble. Quite thymectomy if you haven't it done, for example, in an early onset person. There are other things you should be thinking of. But if you have no B cells, I don't think you'll do any harm by giving more rituximab. You just throw the money down the sink, though I suspect you're not doing much efficacy wise. That's my impression of that. IgG4 different from IgG1.
Yep, indeed. There's one last question I may take before we move on to the break, and the second component. I apologize for the other colleagues who have asked questions. What is the standard rituximab dosing used for myasthenia gravis? Do you want to share the news?
So I'd say the standard dosing is not standard. So the standard dosing is based on lymphoma. That was 375 milligrams per meter squared 4 times. That changed to 1 gram 2 weeks apart with a rheumatologist, more for convenience than anything else. The Rhinomax used 500 milligrams. So that's what as a stat dose, and that's what the evidence base is. And I've come clean as being a 100 milligram user because it used to be expensive in the ITP literature. And my experience was that worked quite well. So if you're not in a completely resource hungry space, 500 milligrams, which is now cheap as a stat dose, I think is easy to justify. More than that, I don't think would do any harm, but I can't see that it's got much use. So there isn't a standard dosing, but the Rhinomax is 500 milligrams stat. What do you think, Chana? Are you good with that?
I would. That's what I've been doing actually, and then I will do the same for MuSK-positive myasthenia as well. But if they do relapse, then I probably will continue maybe a few more infusions every 6 months. Okay. Super. Thank you very much. I think that's all the time we have, folks, for this session.